I've been associated with autonomic nervous system since about 1998. I am not a provider. I have no clinical training other than what I've learned from the doctors, nurse practitioners, PAs, and reading the books on the autonomic nervous system. I'm not a nurse practitioner. I'm not a provider of any kind. I'm a reimbursement consultant. So let's get started. A lot of my knowledge came from this book right here, Clinical Autonomic Dysfunction, written by Dr. Joe Colombo, Dr. Vinnick, and others. It's been out for probably, I'd say, almost 15 years, and you can get that on Amazon. And it basically goes over the parasympathetic, sympathetics, and how you use this to apply towards patient care. Now, why does Medicare and the other insurance carriers want you to test the autonomic nervous system? It's pretty simple. It's evidence-based. And why are they so excited about evidence-based? With the Agency for Healthcare Research Quality, the Physician Quality Reporting Initiative, the MACRA, the MIPS that we now have this year that everyone's going to be trying to get you to make sure you complete. It's all geared evidence-based for a specific reason. Simply, we need evidence-based medicine today, and it's all going in that direction because of the condition that we have patients. 8.3% of all Americans have diabetes, and about 26.9% of those 65 and older have it. 33%, well, about 1 out of every 3 diabetics over 50 have peripheral arterial disease. About 1 out of every 3 hypertensives over 50 have it. About 23% of Americans 65 and older have it. You can see the numbers there in front of you, but you know that peripheral arterial disease is the leading cause of amputations. And if we start doing these kind of evidence-based medicine testing, we're able to capture these things at an earlier stage and hopefully circumvent having to have those amputations. Interestingly, 32% of referrals to cardiologists by primary care are not cardiology related. It seems like something happens, a patient complains of chest pain, or they complain of shortness of breath, and we're automatically sending them over without doing due diligence beforehand, and we end up sending them to the wrong specialist. And orthostatic intolerance is the primary cause. No, I need to change that word. It's the primary cause of syncope, not the primary care. And orthostatic hypotension or dehydration is the primary cause of orthostatic hypertension. We're going to get into some greater details on these in a little bit right here. But after doing this testing in offices all over the country of mostly primary care physicians, neurologists, pain management physicians, we find that about 31% of the CHF patients are being over beta blocked by the cardiologist. And that's causing the patients to have other kinds of symptoms that we're going to go into in a little bit here. 80% of the strokes and heart attacks are preventable. The heart attack I had in June of this year, where I had 100% blockage of my right artery, was preventable. Had I been watching my diet, had I had an ABI a month before, chances are I wouldn't have had that heart attack. Diabetes, hypertension, obesity, they're all treatable and not always permanent. I know we always think that once a person has diabetes or hypertension, that it's going to be permanent. Not necessarily. Patients can change if they have the right help on this. So that's what we're talking about on evidence-based. And this is what Medicare and the Agency for Healthcare Research Quality is trying to push through to us. COPD, as you know, it's the 4th largest killer of Americans. But yet, I find in most primary care offices, they're only doing the testing for evidence-based testing on the patients, typically on less than 13% of their patients with COPD, with asthma. And yet we know that 21% of American adults have some kind of pulmonary dysfunction. You sit there and say, okay, why are you giving us these numbers? It's because I'm trying to stress to you that the insurance industry, Medicare, private insurance, Blue Cross, Aetna, etc., they all want the testing to capture these things at an earlier stage so as to reduce catastrophic costs later on. And they look at, and some of you may have seen that movie with Tom Cruise where it says, show me the money. Well, I'm going to show you the money. Primary care procedures like destruction of lesions, the reimbursement for those have gone down. Joint injections, the cost has gone down. Removing impacted cerumen from the ears, the cost has gone down. What's been going up with the insurance carriers on how much the insurance carriers are paying are diagnostic tests like 91065. That's a breath hydrogen test, 93922. That's gone up 110% on payment. That's an ABI. Spirometry has gone up. Autonomic nervous system testing reimbursements have gone up 38.9%. And if the insurance carriers are putting more money into diagnostic testing, that tells you what they're looking for. It's because they have all the actuarial tables that if they figured out, again, if they spend $70 for a spirometer today so that they can capture pulmonary dysfunction at an earlier stage, it ends up saving them a lot of money in the back end. So if we just even followed the money, we would see that diagnostic testing makes a lot of sense. The PQRS, Physician Quality Reporting System that we had over the last since 2011, and this year we have MACLA and NIPS. One of those that's included in that is orthostatic blood pressure on every diabetic patient routinely. This last week right here, Monday, I went to my cardiologist. They didn't just do a sitting blood pressure, they did a standing one. They're looking for the orthostatic blood pressure to find out if patients are suffering from orthostatic hypotension. And yet, I go to a lot of primary care offices and ask them, do you routinely ask patients if they stand up quickly, do they get lightheaded? We're not looking for orthostatic hypotension routinely, and yet that's the number one cause for syncope. So we need to kind of go back to the whole concept of looking for evidence-based medicine, or practicing evidence-based medicine. Autonomic testing is also supported by the American Diabetes Association, the Juvenile Diabetes Research, the National Institute of Health, etc. I go all the way down the line of all of these major associations of physicians, and they're all looking at autonomic testing. The standard of care article right here in American Diabetes or Diabetes Care, it says, the ADA recommends parasympathetic and sympathetic ANS testing as part of the standard of care for diabetes. Yet the vast majority of primary care physicians have not jumped onto the bandwagon yet because they weren't taught this when they went to medical school 20 years, 30 years ago, 40 years ago, however long it's been. So we really need to make sure that we get into the program on this. As everybody on this program right here, or everybody listening to this, knows probably much better than I, because you are medical providers and I'm not, but cardiac autonomic neuropathy results in damage to the autonomic nerve fibers that innervate the heart, blood vessels, and results in abnormalities in the heart rate control and vascular dynamics. If we can get homeostasis in the patient's autonomic nervous system, many times we can stave off or prevent cardiac autonomic neuropathy. And that's what we're looking at in this. Normally, the heart can communicate to the brain, as you learned in medical school and in your training, that it's having a problem, such as pain. But many times, if the patient's heart has been suffering from neuropathy, autonomic neuropathy, and the nerves around the heart have been damaged, there's no signal getting to the brain. And so many times we hear people talk about sudden death syndrome, where there was no warning. Yeah, there was warning, but the patient's brain did not capture that warning because of the neuropathy. So when do we want to detect autonomic neuropathy, or when do you want to do so in your own patients? Well, obviously as early as possible. If you're treating your patients the way you would want your loved ones treated, you don't want to wait until the patient has symptoms and then complains before you start looking for this. If you know that the patient has diabetes, cardiovascular disease, or other kinds of ischemic heart disease, or other kind of problems that's going to affect the autonomic nervous system. Now, you already know, again, better than I, all chronic diseases ultimately lead to the autonomic dysfunction. And the early stages of autonomic dysfunction are always asymptomatic. Patients don't always know. I mean, it's like when we're talking about small nerve fiber damage in the patient's feet, and they don't recognize that it's probably indicative of some kind of neurological problems with their feet. They just think that it's normal for their feet to hurt as they get older. As I get older, I'm 61 years older, as I get older, I find that I have different kinds of pains in different areas. But I've been trained through working with this for years to start bringing these things up to my providers. A lot of patients are not. So you have to ask the right questions on this kind of stuff. So why does Medicare want it? Well, as you know, Medicare knows that ANS maintains primary neural control of the heart, and we're looking for the homeostasis between the sympathetics and the parasympathetics. Every one of you have been trained that the entire body is controlled by the sympathetics and the parasympathetics. Where the sympathetic speeds up the heart, the parasympathetic slows it down, and everything from blinking, closing your eyes, all the way to the reproductive side is controlled by it. It's amazing, though, when I'm talking to the doctors that's been practicing for 20 or 30 or 40 years, they say, yeah, this brings back memories of what I learned in medical school, but I don't really apply it every day. Well, once you kind of start thinking about it from this standpoint, you're really addressing more of the cause of the problems rather than just addressing symptoms. And that's where we all want to be. I've already said this right there. You already understand the inability to maintain homeostasis may lead to these kind of problems: heart disease, heart failure, diabetes, the other serious kind of problems that you're treating on a regular daily basis. You also know that the nerve disorder should be expected in all patients who have had type 1 diabetes for more than 5 years, because diabetic neuropathy is what we're trying to capture at an early enough stage that you can actually treat it, not wait until it's already taken over. I'm not going to get into which kind of drugs need to be given to the patients because I'm not qualified to do so. But a lot of times we are treating, again, the symptom rather than the cause. And if we're actually doing this kind of testing on a regular basis, and we do our homework on this, it's amazing how often you can bypass the symptoms, go straight to the cause, and we'll get into that right there with you here. You can objectively measure your patient's response to these kinds of problems. Like if we're talking about cholinergic antagonist, if we're talking about raising the sympathetics or the parasympathetics, you already know how to do all that right there better than I do. But let's don't fall into the habit of, oh, well, the patient's having sleeping problems. Let's look at Ambien or Restoril. Those things have all kinds of side effects. I know. Earlier this year, they had me on Restoril after I had a knee replacement. And I felt like my IQ went down, my cognitive scores went down, my cognitive function went down. Don't always just jump into what we've typically been doing in the past. Let's look at, again, going after the cause. It might have been, and I believe, with many patients, as you're going to see, that the insomnia, the sleep disorder, the sleep dysfunctions is more of being caused by an excess sympathetic and reduced parasympathetic on that seesaw. So instead of giving me Ambien or Restoril or something like that, we need to be addressing the cause of the problem. Autonomic neuropathy, we're looking at many things that affects the digestion, the bowel, the bladder function. A lot of times we see you can't turn on the TV without some kind of an ED commercial. And by the way, if those drugs really did work, would those patients still be in 2 separate bathtubs at the end of the commercial? I don't think so, if they really work. It affects perspiration. The only symptom I had, by the way, on my heart attack, the only symptom was hyperhidrosis, sweating. No pain, nowhere, just simply that. A lot of times we're missing those kind of problems right now. We're looking at hypoglycemia unawareness. That's really big with a lot of patients. I deal with a lot of endocrinologists, and they're telling me that that's a huge problem with them. Again, I don't know enough about endocrinology to understand what I would be looking for, but they're telling me that that's part of the entire autonomic nervous system that we're looking for. So everything in the body we're looking at has some kind of relationship to the autonomic neuropathy. Patients coming in complaining about fatigue, malaise, no interest in going shopping, no interest in spending time with their grandchildren, no interest in going to church, any of that kind of stuff. A lot of times, instead, it's we first think typically, oh, it's a vitamin deficiency, it was a B12 problem. But if you test the patient with an autonomic nervous system and look for, you may find that the patient has a parasympathetic excess and a sympathetic reduction. And a parasympathetic excess can many times cause the quality of life problems we're having. So we want to be looking for that as well. Well, your Medicare patient suffering from depression. Well, many times that can be because of, again, parasympathetic excess. And that's easily treatable. As we get older, we find that these sympathetics and parasympathetic, uh, what's the word I'm looking for, imbalances, the lack of homeostasis grows according to the age as well. And again, we can have autonomic neuropathy presenting up to 20 years earlier, as long as if the patient has diabetic autonomic neuropathy, if they have cardiac autonomic neuropathy. And many times, again, it's asymptomatic. So we want to be testing these kind of patients on a regular basis. We look at Medicare, they're in Georgia. Here's a list of the diagnosis codes that Medicare says, and updated recently September 30th, less than a month ago, that they want these patients tested. Diabetes mellitus, idiopathic peripheral autonomic neuropathy, orthostatic hypotension, tachycardia, etc. And then if we look at the non-Medicare patients, they're typically covered for all of these kind of things. Why would we be doing this right here for menopausal syndromes, premature menopausal symptoms? A lot of times you'll find it's really high sympathetics with the patients is causing the excess or the very heavy menopausal problems and symptoms. So you want to be testing that and addressing the cause again rather than the symptoms. Hypertension, you already know diabetic autonomic neuropathy always precedes cardiac autonomic neuropathy. Again, PMS, almost always very high sympathetics if the patient's having heavy PMS problems. Depression, almost always high parasympathetics. You say, well, you're really throwing everything into generalities. Yeah, I can't say always, but I can say almost always based on the reports from Agency for Healthcare Research Quality and American Neurological Society that they come out with these kind of studies. Insomnia, I don't know how many times, last night was one of those for me. I just could not turn my brain off. I think I finally dropped off about 3 o'clock this morning. Did I get up and take Ambien or Restoril or anything like that? No, I got up and took something that was going to raise my parasympathetics and lower my sympathetics, and that was a shot of bourbon. I only dropped off about 3 o'clock this morning. It happens a lot with patients, and it's a sympathetic, parasympathetic problem. And no, I know that bourbon's not one of the things that you guys generally recommend for this, but it worked for me last night. Again, I'm going through these things that you guys already know. Orthostatic hypotension, postural tachycardia. How many times do you ask patients, or do you have your MA or whoever's taking a patient to the room, do you ask the patients, if you stand up quickly, do you get the same feeling today that back in the 70s took you a marijuana joint to achieve due to vasoconstriction of the blood vessels? Well, that again is going through what we're looking for is the orthostatic hypotension or postural tachycardia due to vasoconstriction of the blood vessels. Congestive heart failures. The Journal of American College of Cardiology, as I mentioned earlier, says 32% of CHF patients are being over beta blocked. When my dad passed away several years ago, we went through all of his meds and found out that he was getting beta blockers from his cardiologist and getting them from the VA. And whether or not that had anything to do with dad having a fatal heart attack, I don't know. But I know that being over beta blocked is causing all kinds of problems such as sleep difficulties, lack of sex drive, depression, etc. So we need to be looking for these kind of things. It's a common cause of syncope according to the WebMD and eMedicine. Orthostatic hypotension is #1 cause of syncope according to the American Family Physicians. All of these things, as you already know, I don't need to remind you of those things. I just want to let you know that, again, we're going back to trying to treat the symptom, the cause, rather than just the symptoms. So how confusing is it to balance the autonomic nervous system? Well, whether or not you're using the ANS or you're using LD-TAC or whichever system you're looking at, take a look at the balance on the sympathetics and the parasympathetics. And you may find sometimes you'll be surprised. I was doing a speaking engagement for a pain management practice. And I explained to them that while I can lie about being in pain, my sympathetic nerves cannot. They're not going to lie. So when you're doing a Valsalva test during the autonomic nervous system testing, if a patient shows very high sympathetics during the Valsalva test, that's a very good indication that the patient is having a lot of physiological pain. But if a patient comes in and reports, I'm in a level 8 pain, I'm in a level 9 pain, and you're doing the ANS test on them, and they're showing a very low sympathetics during the Valsalva test, That's a very good indication that the pain the patient may be having could be either psychological, psychosomatic, or the patient may be looking for drugs. Because again, I can lie about being in pain, but sympathetic nerves cannot. And yeah, if you work smarter, you provide good medicine, you can have fun with